On behalf of the University of Iowa Hospitals and Clinics, we want to thank you for attending today's presentation with Dr. Holt. Our faculty's goal is to share information with you to use as the latest therapies and techniques in medicine and answer your questions about how to partner with us in the care of your patients. These are informational presentations to enhance your clinical practices and to provide you with the most updated information that we have. Today's presenting physician is Dr. Holt, so I'm going to turn over to him so he can share with us a little bit about himself, and then he'll go right into his presentation. So Dr. Holt, welcome, and thank you for presenting today.
Thank you. It's a pleasure to be on. And as was mentioned, my name is Josh Holt. I'm one of the pediatric orthopedic docs here at the university. And my goal of the presentation today is to be both educational and hopefully remind you or teach you something new about pediatric orthopedics and a few selected topics that I've chose to highlight today, but also that this is a functional and a helpful presentation in helping you to navigate some of the referral processes and best ways to contact us and me and the Department of Pediatric Orthopedics in general, so that we can improve patient care across the state and here at the hospital. So by way of introduction, as was mentioned, my name is Josh Holt. I'm the happy father of 3 awesome boys and the lucky spouse of an amazing wife, Allie, that you see there. My journey started in Salt Lake City, Utah, where I was born and raised, and then my wife and I decided to see some of the country and travel around during my training. So I actually did medical school at Chapel Hill in North Carolina, where I got what I think was a great education, and decided to continue my orthopedics residency training here at the University of Iowa. So I came here in 2012 initially, completed my residency here in orthopedics prior to going to San Diego, California at the Rady Children's Hospital, where I furthered my orthopedics training in pediatrics and particularly in scoliosis. And then was fortunate to have the opportunity to come back to Iowa 2 years ago and join the faculty here as one of the pediatric orthopedic surgeons. And it's been a great 2 years to this point, and looking forward to continue to develop my practice and develop the relationships I have with multiple providers around the state and here at the hospital. So in general, I have no important disclosures or anything relevant to this talk. As I said, what I'm hoping to do is to be able to cover several pediatric specific topics in orthopedics, some of the more common troubles that you see around the state, kind of these 4 pediatric trauma, which will really focus on elbow fractures and some of the treatment of those. Spine pathology, again, really focusing on scoliosis. All of these are pretty broad topics and could go a lot of ways. Hip dysplasia, really focusing primarily on infantile DDH, and then child and adolescent hip, not IP, drop the H off of there. And some of the things that we're doing here at the university that are pretty cutting edge in treatment for child and adolescent hip pathology. As I mentioned, really the goal of this presentation is hopefully pretty broad and provides information for various different providers here at the university, whether you're a pediatric subspecialist and you're seeing a kid in clinic who happens to have a musculoskeletal complaint as well, kind of how to best navigate that, how to set up a referral to us in the pediatric orthopedics clinic. Whether you're a provider here at the university who's in one of our outreach clinics at IRL or one of the other clinics around the state, kind of how to best manage musculoskeletal troubles that you may come across. But then also more broadly, if you're a general pediatrician at any level in the state at a community practice or otherwise, and then also even kind of more focused in on general orthopedic providers around the state who are taking call and managing fractures and acute trauma that, you know, we all see kids, and if there's questions or troubles that come up on best management of pediatric trauma, certainly there's things that we've done here and just in the last year changed a lot of the programs that we have, a lot of the referral pathways, a lot of our kind of in-house call coverage, to really try and help streamline the process and get kids the best possible care that they can get. So what I want to do is really, with each topic that we go across, is kind of highlight everything with not only an overview of the individual topics, but then when does a referral need to be placed? How urgent does that referral need to be? What's the best way to go about getting these kids here to the university to be seen by myself or one of my pediatric orthopedics co-partners? And so kind of we'll highlight each of the 4 topics with that in mind. So really, no matter which one of these you may be, I'm hopefully that today's presentation will help provide some information as well as some functional tools and opportunities for you to contact us and kind of get kids in a streamlined process. So we'll start with elbow trauma. We all see trauma. Elbow trauma is very common. The upper extremity is the most commonly fractured limb, and particularly elbow fractures are the most commonly operated on extremity trauma in kids. It's really a national trend, and I had the privilege of publishing a couple different studies where we looked at 2 big national databases and really found that this is a nationwide trend where kids, and particularly supracondylar humeral fractures in kids, are really being managed more and more and more by children's hospitals, by tertiary care centers, by pediatric orthopedists for a variety of reasons. And certainly the least of those reasons is because any of us think that we're better at it than anyone else. I certainly don't think I'm better at it. Really, it's a familiarity. It's recognizing patterns. It's seeing enough of these that you know and recognize warning signs, that you know and recognize potential difficulties you may have with fixing them. But then also just the process that we have set up here to be able to treat them efficiently, to be able to treat them timely, to have the follow-up arranged, to have the cast room set up, to have procedure suites available if we need. And I'll go through a few case examples and try and highlight some of these things where it's not necessarily just about the surgery itself, but it's about the follow-up, it's about the post-operative care, and it's about the process that hopefully we have relatively streamlined here to help outside providers, to help pediatricians know who and when to send. And as I said, we'll go through a few cases now to try and highlight some of those things. In that study, those couple studies I just showed, again, what we found is that the transfer rates have been steadily increasing over the last 15 years. Here showing that really those transfer rates are the highest among non-tertiary, non-metropolitan, non-teaching hospitals. What we found that really in the Northeast and in the West are the 2 areas that have seen the most, where they've really, really streamlined care, where most of the kids who are ending up getting surgery are really being treated by kind of centers of excellence, places who see and recognize patterns and have enough volume to know when things are going right or wrong. The surgery rates haven't changed too much. It's actually the surgery rates have decreased in general. And again, mostly we see that in non-trauma, non-teaching hospitals and non-metropolitan, where the surgery rates have gone down a lot because more and more of these kids are being referred and triaged to academic centers, children's hospitals, teaching hospitals. And one great thing that we found is that the surgery has changed too. So even though the rate hasn't changed dramatically, the type of surgery these kids are getting is changing. So the CRPP on the top there is closed reduction and percutaneous pinning, which is less invasive, shorter recovery, no big scars, no big wounds to worry about. We're able to align those things, get the bones pinned, treat them in a cast, whereas the rates for open reduction, a big open approach, a lot of dissection, more risk to neurovascular structures, that rate has gone down. We think and we suppose that this is because, again, more and more of these fractures are being managed by people who just see a lot of them, people who get more adept of recognizing small changes, recognizing small differences in x-rays, knowing little tricks and things to be able to manage them in closed fashion. So here's one case to highlight. This is a case that I saw. This girl was seen at an outside emergency department, and the orthopedist on call, who's actually a great friend of mine and someone I know very well, he's a great orthopedist. He saw this patient in the ER, and it's hard to even see there, but she has a fracture through the distal end of her humerus. It's not greatly displaced. It's not, you could look at those x-rays and not see any injury at all. But as we zoom in on the elbow, when he saw her at clinic follow-up the next day, there's a couple things that I see now clearly in retrospect. I see him more clearly, but a couple things that he didn't necessarily appreciate. That being, you see that medial epicondyle is off of the humerus. But more important than that, you see that the whole elbow joint is shifted medial. There's actually a fracture line through the cartilage that you can't really appreciate on these x-rays that comes out the lateral side. That raises concern and raises worry that even though this isn't really displaced, certainly doing something to fix it and hold it there rather than to let it be able to drift would be ideal. in retrospect, again, the surgeon who I, again, appreciate and like, and he's a great guy, he didn't quite see that and recognize that. And so when he saw this patient back a month later after treating her in a cast, you can see there that the elbow is really starting to drift off. It's shifted medially as well as falling into a lot of varus. When he saw her back a few weeks later, you really see the migration, or that ulna is migrated very proximally. It's shifted quite medially, and it's fallen into 15 or 16 degrees of varus, which is about 20 degrees off of where it should be. So then she healed and she was done, and she came back to see him 6 months later with an elbow that was very cocked, having a lot of lateral elbow pain, the ligaments on the lateral side really stretched out from the deformity that came to this elbow. So this is the films when I saw her in March of last year. You see a lot of varus there through the elbow. The medial side is really collapsed and healed in that position. So we took her to the operating room, did an osteotomy where we closed down that lateral side to realign the elbow. Here's some of the fluoro shots in the post-op films. As you can see in the fluoro shots, I fixed it with both the plate as well as those pins. There's various reasons for doing that, what I won't go into now, but what I wanted to highlight with this case is when I saw her back in clinic, I planned to take her to the procedure suite to be able to take her cast off and to be able to pull these pins out with having her comfortable and not flailing and not moving. I knew that the osteotomy, wasn't healed when I was taking these pins off, and I wanted to be able to assess that healing and get her back into a cast without her moving and flailing. A lot of providers don't have that easy option to be in clinic. I was in clinic, had an extended break, went into the procedure suite down the hall, was able to do this and then come back to clinic. It wasn't a full day event. It wasn't an operating room event. It wasn't one of my operative days. And that's something that we have the ability to do here, is use our procedure room to be able to do procedures, small procedures to kids, whether it's a cast change in a kid that's really painful, whether it's management of something we don't want to shift or move with the patient awake and kind of flailing like kids often do when you're changing casts and removing casts. So we were able to do that, get her back into a cast. She went on to heal. You can see there that the alignment of the elbow is totally normal. I wish I had clinical photos of this young lady, which I don't, but her elbow went from being very, very, very markedly varus to neutral alignment. I've actually just recently gone back and taken this plate off now, so she no longer has hardware, and those are my fluoro shots from January that you can see that alignment on the left is nice and straight alignment, even got her into a couple degrees of varus, or excuse me, valgus, which is normal, and then her motion is preserved. So really trying to highlight just some of the options that we have here at the university that a lot of providers in the community don't, that streamlines and improves patient care. Here's another one, again, not highlighting something done good or poorly by an outside provider, but just highlighting pattern recognition. 2-year-olds don't fracture their elbows often. As a pediatrics provider, it's pretty rare that I see a 2-year-old with an elbow fracture like this. Certainly someone in the community might see this, once every several years, to be honest. This kid was seen by an outside provider here in the state, was appropriately managed with surgery. They were taken to the operating room, and these are their fluoro shots. You can see that image on the left really got great alignment. There's nothing better or different that I could have done to restore the alignment. It looks really great. But what wasn't appreciated was the amount of comminution and the amount of cartilage damage. Back to these original films, you can see both on the medial and the lateral side there's comminution. So essentially this elbow is floating there without a lot of structural support. So a pretty typical fixation with this would be 2 or 3 pins. Two pins were placed, they're reasonably positioned, but the trouble is without recognizing the amount of cortical bone on both the medial and lateral side that's fractured. Unfortunately, this patient went on, as you can see there, on the 5th of June. 6 days later, came back to clinic and had completely fallen off. The pins didn't hold at all. The pins had migrated, the fracture had totally lost reduction. So they were referred to my clinic the following day. We took them to the operating room. And as you can see here, this construct isn't what I would call a normal construct at all. 2 really, really long pins from the lateral side, a 3rd pin from the medial side, which is not something that I do routinely, but do when I have that medial comminution and don't have the support that I need from the cortical bone. She went on to heal. Here's her films after we took the pins out. Again, you can see the alignment on the left is back to preserved. Again, not saying that this is something that would have been easily recognized or noticed, or that kind of this quite abnormal construct that I have here would have been a go-to for most fractures in this case. It's just pattern recognition, recognizing that a 2-year-old, this isn't really normal. It's not common to see. And so you have to look for these abnormalities and kind of different fracture patterns, which then make you change the way that you fix them. So that's something that we are fortunate enough to see here, is a lot of volume and are able to manage these differently. The last case I'll use here, just again to highlight some of the opportunities that we have here just to see volume, is this is a 6-year-old who had an injury, and looking at these films, honestly, you can just see a small non-displaced lateral condyle fracture, which is what the provider saw. He managed them in a cast, which was probably appropriate initially. The trouble is at follow-up, you can see something different here. You can see a bunch of healing and a bunch of irregular bone there on the proximal radius. You can see that the end of the radius at the radiocapitellar joint is real jagged and abnormal looking. This certainly would raise concern and raise suspicion and isn't normal at all for a lateral condyle fracture. And if we go back to these pre-films, you can actually see a lot of that ossification there along the radial shaft. At the time of injury, that shouldn't be there. There's no healing yet, telling us that there's something abnormal about this. There's something different. So the provider got this MRI, which shows all this extra signal in the proximal radius. It was read at that time as osteomyelitis. And so he called me actually from clinic when this patient got the MRI result. We had the patient come to my clinic that day. We were worried about osteomyelitis from the read. We didn't have this MRI at the time, but they came and brought their MRI with them. And as I scrolled through this MRI, as you can see these images here, again, all that extra signal in the proximal radius. Then we start seeing some abnormality here. We're starting seeing this kind of circular structure there at the top end of the radius. And on this view, you can see that perfect circle that's staring right at us. That's the radial head, and it's completely flipped 90 degrees in the wrong direction. So rather than facing up towards the humerus, it's actually facing out towards the lateral aspect of the elbow. And again, here we see the rest of the radial head there. So this kid had broken off his radial head, which had shifted it completely 90 degrees and migrated distally, and had then healed to the radial shaft in the wrong position. So I actually took this kid's case and called a few people I know from fellowship, called a couple of the other pediatric upper extremity surgeons that I know in Philadelphia and otherwise, and asked them, and no one had seen this. No one had seen a technically missed radial neck fracture with complete displacement of the radial head and complete healing to the radial shaft. So I took this kid to the operating room. You can see my joker there on the 2 radiographs on the left, kind of outlining where the radial head was. The pictures are intraop intraop photos, where you can see there we're looking at the articular surface of the radius. That should be flipped 90 degrees, kind of counterclockwise and articulating with the humerus, but it was pointing out towards the skin and otherwise. So we did an osteotomy. We fixed it with a plate, which again, not common to fix kids' forearm fractures with big plates and screws. Usually it's pins and wires and things. But we wanted to fix it rigidly so he could start motion and get things moving, as well as hopefully preserve the blood supply after we did the osteotomy and moved the whole radial head. Fortunately, he's gone on to do great. I didn't put the post-op films. I just saw him back in clinic this week. Actually, we took him to the operating room 2 weeks ago and took this plate out. He's gone on to heal it well. We're seeing good ossification of the radial head to suggest that we did preserve the blood supply. So again, not a common case, a pattern that's not typical that was unfortunately missed. And again, it's pattern recognition. It's seeing enough of these and seeing a lot of these to be able to see that, you know, on those initial films, we see that ossification there. That's not supposed to be there. You wouldn't expect that on a lateral condyle fracture. So again, picked a few cases to highlight, but really what I want to do is, you know, when is referral to pediatric orthopedics necessary? And what I would say with all of these is overarching is contact me, contact us. Send me a message in Epic, send me a page, send me an email, call me directly. If there's questions, if there's worries, if it's not typical, if you're wondering if it's something that you can manage in a clinic, if you can manage in a community clinic or otherwise, feel free to contact me at any time. In general, if you have any uncertainty or any question, we're always happy to see patients. Feel free to refer them. My general recommendation would be patients that you can manage in a clinic, that you can manage with a cast or a splint. is really non-displaced long bone fractures, a distal radial fracture that's not displaced, a both bone forearm fracture that's not displaced, fractures of the bones of the hands and of the feet that are non-displaced and don't involve the joint surface. Those are things that can be routinely and confidently managed by non-pediatric orthopedics providers. Patients that should be referred to us and patients that we should evaluate are those listed here. Patients that might need a reduction. And those are ones that I would say, call me if they come into your clinic and you're questioning if they need a reduction, if they need to come to the ER, if we can set up to see them in clinic that same day or the next day. It makes it a lot better and a lot easier for the patient if they can be seen first where they're going to get their treatment. If it's something I can see in clinic, then I'll set up for clinic that day or the next. If it's something that's going to be better, that's going to need some sedation, you're going to need pain control, we'd set them up to come to the ER that day and we'd be able to manage them from the ER. So if you contact me and let me know, just from your clinic, that's something I can help to arrange. Certainly any fractures in or around a joint, a couple of them that I showed there, in and around joint, they're a different beast and they're kind of require a different set of eyes to look at them. So those are ones that I would always recommend, consultation with us and potential referral here for us to manage them. And then any acute fracture with a significant soft tissue swelling, any sort of neurovascular compromise or other red flags or other worries you might have, certainly worth referral to us. I'll show this slide several times throughout the presentation, but a lot of different ways to contact me through Epic Message, through paging me, through emailing me, through calling the office. A lot of providers have my cell phone and call me, and I'm happy to share that with you. You can contact myself or Kristen afterwards, and we can get that to you. Next, we'll quickly go through spine pathology. So really, there's a lot of different spine pathology, from non-displaced pars defects there on the left to a high-grade slip that you see there in the central, to scoliosis and various different kinds of scoliosis you see there on the right. So again, what I want to do is just quickly go through some of the basic of scoliosis, and then we'll kind of get into a couple cases and the specifics of cases you guys can manage on your own, cases that need to come see me urgently or non-urgently or otherwise. So really kind of the normal curves of the spine, there should be some curve in the sagittal plane, but otherwise they should be straight in the frontal plane and straight in the axial plane. There shouldn't be rotation or other abnormalities. When we start seeing those changes, that's when we start looking at scoliosis. Again, from the Greek word meaning crooked, the Scoliosis Research Society describes as anything with a Cobb measure on the coronal plane more than 10 degrees. And that's kind of where my recommendations would shift, is that 10-degree mark is, as we'll get to later, really when a referral should be made if we start seeing higher than that. There's a lot of different types of scoliosis. We won't go into any depth on any of these other than idiopathic, but they are all a little different. The management of them is all a little bit different. From congenital, like the last picture I showed, to neuromuscular, like this patient that I recently treated, to syndromic, to secondary, whether it's from a trauma or radiation or a tumor or things like that. All things that require kind of particular care. I'd say any of those first four certainly require referral and management by us. The last one is the one I'm going to talk about the most, which is idiopathic, which is by far the most common and one that you'll probably all see in your clinics at some point. And some of those can be managed by you. So really, when we're talking about idiopathic scoliosis, we're talking about two different types: early onset and standard adolescent. And really, there's a few different classifications and different scales and things, but really think of age 10. So anything less than age 10 is early onset. Anything over than age 10 is considered adolescent. It's pretty common. We've all seen it. We probably all know someone who has it, up to 3% of the population and higher than that in some populations. Fortunately, most of these curves don't get big enough that they require any particular treatment. It's only about 1/3% of kids who have curves that get big enough that we actually have to do some sort of intervention. By far more common in females. Once you start talking about curves that are big enough to require treatment, you're up to about 10-to-1 female to male. Most of the preclinical presentation is found by either some sort of screening or some sort of radiograph who just happened to notice the curve in their back. Most kids are asymptomatic. School screenings have kind of gone through a few different iterations of recommendations or not. U.S. Preventive Task Force actually recommended against kind of routine school screening in 2004. The Scoliosis Research Society recommends some sort of judicious screening officially in 2008. But for the most part, it's screening by a pediatrician annually. It's screening during sport physicals annually. It's not something that's routinely done in schools anymore, and so it's us as providers' job to make sure that we screen and really look for this. We won't go through all the details, but typically it's done through a simple Adams forward bend, where you're really looking to see any height difference on the thorax or the lumbar spine, secondary to that rotational deformity. It's pretty rare that kids have other symptoms from this. They really shouldn't have neurologic symptoms. They really shouldn't have significant pain. If they're having night pain, if they're having pain that's limiting activity, if they're having other kind of red flags, that certainly requires further workup, as it's oftentimes not idiopathic. So what do we do? What's the treatment? Sometimes we observe, sometimes we don't do anything. We keep an eye on it, and it all depends on the age, the curve size, and any progression of this curve. Sometimes we cast. Again, depending on the age, the curve size, and curve progression. We take them to the operating room and treat them with a cast. There's a few different techniques that we use for this. Sometimes we brace. Again, depending on the age, depending on the curve size and progression. A little bit repetitive there, but that's really what it is. Trying to find these kids who are going to progress, kids who are at risk for getting a big enough curve that we would need surgical intervention, and doing what we can to minimize that risk, to keep curves small. Sometimes they get big though. Sometimes, depending on age and curve size and progression, we recommend surgical treatment. Here's a patient I recently treated with posterior fusion for a curve that progressed in a relatively skeletally immature patient. We took her to the operating room to fuse her spine. Some of the other treatments that we won't go into too much depth because there's not a lot of great evidence. I like to really stick with evidence-based practice, but certainly the Schroth method of therapy, it's a great physical therapy exercise. It's pretty detailed and pretty extensive for a lot of patients. The people who do it and really commit to it, we have seen curves stabilize. There's not a lot of Schroth certified providers here in the state. There's a few. We have one here at the university, and there's a couple others throughout the state. But that's certainly something that some patients prefer. Chiropractic manipulation, electrical stimulation, other treatments that have been recommended, they don't really have any great science behind them. They don't really have any great outcome studies to suggest that treatment. So it's not something I routinely recommend, but things that you may hear or come across. So again, with scoliosis as the kind of poster child, but looking at other spinal deformities as well, when to refer. Again, it's always okay to contact me, message me, page me. If you're uncertain or have a question, always okay to send. But in cases where it's okay for you to maybe manage this, again, curves that are less than 10 don't meet the classification for scoliosis. Kids aren't having pain. It was something that was picked up on a chest x-ray or a little asymmetry that's noted on a sport physical by an astute and kind of attentive care provider. Get an x-ray and you see a curve that measures 8 or 9 or 7 degrees. Not something that you necessarily need to refer to us straight away. It'd be totally appropriate for you to see them back in 6 months' time, for example, or a year time, for example, get another x-ray or just even do another clinical exam. And if the clinical exam hasn't changed, if the x-ray hasn't changed, if family haven't noticed any difference in any postural differences, certainly something that can be managed by you in your practice. If curves are less than 20 in kids that are pretty well done growing, you know, a mid to late teenager, again, when they're 15 and they're getting their school screening done, someone notices a curve and you get an x-ray and you see a curve that's 15 or 16 degrees and they're done growing and their growth plates are closed and family haven't noticed any curve change, something that you can certainly manage. See them back maybe once more in 6 months or a year and make sure nothing changes. But otherwise, something that if you're comfortable managing can be done by yourselves. Patients that I recommend you send to a pediatric orthopedist for manage are a large percentage of these. So any patient who's less than 10, again, we look for these other causes. Adolescent idiopathic scoliosis, they have to be an adolescent. So if we start seeing curves in younger kids, even if it is idiopathic, we do have to do a workup with MRIs and ultrasounds and other imaging to make sure it's not one of these other causes. Patients that's still growing with a curve that gets over 10, even if we don't start treatment initially, it's something that we definitely want to follow, something that we want to be able to trend over time, because as you can see, the treatment depends not only on the number, the curve size, but also progression, change in that curve over time. Any patient with any sort of concerning physical exam, again, pain, neurologic abnormalities, balance difficulties, anything that is not seen in a typical, teenage kid, certainly send to us so we can work it up and make sure we don't have one of these other more concerning pathologies. If you are managing and you see a curve that starts at 8 and then gets to 16 and then gets to 19, send to us. Any of that progression, we want to make sure that we're managing and intervening appropriately as needed. And then those other pictures I showed, spondylolisthesis, congenital scoliosis, pars defects causing pain, those are things that we want to get sooner than later. We want to start treatment. Even if it's not surgery, there's various treatment modalities we can do to try and mitigate and minimize the risk of needing surgery in these patients. So again, there's my information. Happy to talk with you about any of these patients or help you to triage them and get the appropriate follow-up they need. The third of 4 topics that we'll quickly touch upon is hip dysplasia. So this is pretty common. A lot of us take care of young kids and do hip screenings, and it's something that clinically we should be doing on every patient. In America, we don't do routine ultrasound screening on all kids, so it really is up to the providers to get a thorough clinical exam and look for those red flags that we'll talk about here that might prompt the need for an ultrasound or a referral. So the incidence of hip dysplasia is pretty common. So up to 1 in 100 babies have some degree of instability on the hip. That's something you only know if you look for it and if you feel for it. Hips dysplasia that are dislocatable with true dysplasia is much less common. It's only 1 in 1,000. It's a little higher in some populations. The left hip is more commonly associated. So if you have to choose, spend a little more time and do the left hip first before the baby starts getting mad at you. Risk factors that are really important for hip dysplasia are family history. We see that in a lot of patients. Females are much more commonly affected. Firstborn with a tighter uterus, more likely to be affected. Breech presentation is certainly a high risk factor. Low fluids or high birth weight, those are things that just package that baby tighter and increase the risk of hip dysplasia. And then postnatal positioning, not something we worry about too much now with most of the baby carriers and things, keeping the legs abducted and the hips flexed. If you see one of these conditions, spend a little extra time looking for hip dysplasia. Conversely, if you feel like the hip's a little bit unstable and you feel a little slide or you feel a true dislocatable hip, take a little time and look for these other conditions because oftentimes they run together. So what's your clinical exam? What should it be in a newborn? Examine one hip at a time. You really got to make sure the baby's relaxed. You're not going to feel a hip that's subluxatable or dislocatable if the baby's fighting you, if they're tensed, if they're resistant to you examining them. So have them freshly fed or even feeding at the time. Have them nice and warm. I oftentimes do the exam on the mother's lap. So you use her legs as a table to be able to keep the baby in a comfortable and relaxed position. Things that you're looking for is asymmetric abduction. This is a tricky one because you're certainly strong enough to push that baby's hips down to the table. Even if the hip is dislocated, you're almost certainly strong enough to push it down to the table. So you really got to do this gently, and you're just trying to see where that muscle tension starts to get tight. And you compare it side to side, and we're looking for any sort of asymmetry like you see in this photo here. We're looking for abnormal skin folds or creases. Again, suggestive of a more dislocated pathology, but certainly something that may trip you off or may make you want to do a little bit of extra clinical exam to feel for a dislocatable hip. And then the provocative maneuvers that we're all aware of, the Barlow test where the hip is located and you are bringing the hip towards the midline, adducting and putting a little posterior pressure, trying to dislocate the hip. And then the Ortolani test, you're doing the exact opposite. You're abducting the hip out and putting a little bit forward directed pressure on that trochanter, trying to see if the hip is dislocated, and you're feeling that clunk of relocating the hip. As kids get a little bit older and they're not in that real newborn stage, the exam changes a little bit. Those first two are the same, so you still see the skin fold asymmetry. You can still see that abduction difference. Ortolani and Barlow tests are usually gone by 2 or 3 months. The hip gets tight enough that it stays dislocated, unfortunately, or the hip locates and stays located. So really, by the time kids get to 2 to 3 months, it's much, much, much more unlikely that you're going to feel that true Ortolani or Barlow. At that stage, though, you may notice this Galeazzi, where you're really looking for the height difference of the femur. So with the feet symmetrically planted on the floor, you're looking for a difference in height, where really you're only going to see this if they have a true dislocation, as that dislocated hip sags posteriorly. If you see any of those exam findings, or the patient has any of those clinical findings that I mentioned, or the family history, female, firstborn, once you get a couple of those, 2 or 3 of those, I would certainly send them for an ultrasound. So if you work here at the university and you want to send your patient for an ultrasound, that's fine. They don't have to come see us and get any special blessing to get a child hip ultrasound. If you work in the community and you have an ultrasonographer who's capable and able to perform an ultrasound, that's fine too. Get an ultrasound to confirm and to evaluate that hip. We won't go through all these measures, but there's several different things we look at to try and assess the hip stability, how deeply seated it is, how deep that acetabulum is. This is the Graf classification, which we won't go through now, but really we can kind of classify these hips ranging in severity. As kids get a little older to 3.5, 4 months, we can't ultrasound through ossified bone, and so then we have to turn to radiographs again. We won't go through all these different measures, but as kids get a little bit older, again, usually 3.5 to 4 months, we start seeing these things on a plain radiograph. So that's when the imaging modality changes from the ultrasound to the radiograph. And we're looking at these things and again, trying to establish patterns. The number that you measure may or may not be all that important or all that telling, but you're looking for trends and you're looking at the patient's age. There's a few different published studies where we really look at this acetabular index and try and kind of stratify that based on the patient's age as to what's normal or what's too high. Treatment that we do, it's quite variable. It's a little hard for you necessarily to tell your patients beforehand what treatment we might offer. If they're young, less than a couple months of age, almost certainly you can tell them we're going to try the PAVLIC. That's going to be our go-to. That's the picture in the top right there. A recent study that just came out showed that if hips are caught early in the first few weeks of life, treated in a PAVLIC harness, even if they're dislocatable, 93 to 94% success of stabilizing that hip just with the PAVLIC harness. So really it is finding these patients and getting them started on the treatment path early. It's really, really successful. Occasionally if the PAVLIC doesn't work, we try another brace. We tried that Rhino Cruiser in the left. If that doesn't work, unfortunately we take the kid to the operating room and do an arthrogram and look at the joint, look for blocks to reduction, try and reduce it closed, and then treat them in a spica cast for 3 months like you see in the picture there. Occasionally we have to open the hip joint, remove some of those obstacles, whether it's a tendon, whether it's other structures that block the reduction, whether it's the capsule. There's a lot of different things that we may have to remove or lengthen to get that hip back in the socket. And occasionally if they're especially late presenting, I've had a few kids presenting, in the 2 to 3 years of life with dislocated hips, that we have to do osteotomies and cut and reorient bones and things to get the joint back to where it's supposed to be. But that treatment pathway, it's variable, but it's what we do. So again, any question, any concern, clinical exam finding, real strong family history, always happy to see these patients and feel free to send them. Patients that you can manage in your clinic, again, the early kid who has a little click. It's not popping in and out, but you feel a click. That doesn't necessarily mean anything bad. Feel free to send them home and have them come back 2 or 3 weeks later. Repeat an exam on them. If the click goes away and the exam feels real stable and they don't have any other findings, not a big deal. If the click stays, they have more family history or they have other red flags, get an ultrasound and see what it shows. You can either do that yourself or you can send them to us and we'll get the ultrasound here. If they're older, then I would get an ultrasound sooner than later. So if the ultrasound shows that it's slightly abnormal or slightly immature and they're really young, less than a week or so of life, that's okay. Maybe repeat an ultrasound in a couple weeks. You don't have to start treatment straight away. See if that hip matures just with time, if they don't have any clinical exam findings that worry you. If they're older though, and they're over 2 or 3 weeks and that ultrasound's not normal, I would send them to us. If they have any sort of abnormal hip exam, other than, again, that click in the first couple weeks of life, send them to us. It's not usually an urgent consult. I've had a few difficult encounters with patients because they get seen and they get told like they need to get down and see us that day or the next day their baby's hip's dislocated. This isn't like a traumatic dislocation. We certainly see them soon. Oftentimes if babies are only a day or 2 old, we don't actually even want to see them too soon because sometimes babies are too small for the harness. The ideal time is usually that kind of 2nd to 3rd week of life. That's plenty early to get them treated. That's early enough that if they do have a slight click or if their hip's just a little loose for the first few days of life and it tightens up, then we won't do unnecessary treatment. So let them know that you're going to send them to us. Let them know that they'll come and see us within the next couple weeks. But oftentimes it is that we actually choose not to see them when they're 4 or 5 days old because the exam is different and more difficult, and we get a lot more out of it if we wait a couple weeks. So again, there's my information. The last thing that we'll go through here shortly in the bit of time we have left is the adolescent hip. So the pediatric adolescent hip. Hip preservation surgery is kind of a common popular term right now. This is something that's really evolved here at the university over the last just couple years. We have a hip preservation team. We have Dr. Westerman, who's done one of these on hip arthroscopy. He's really good with the scope and we can treat a lot of stuff with the scope. Myself and Dr. Willie, we do a lot of these open hip procedures that most of them are kind of, he and I are probably the only 2 people in the state that do them. They're kind of newer. treatments that that are pretty specialized. I work very closely with actually my partner across the hall from me, who does, he's a hip replacement surgeon, and he kind of has a particular interest in pediatric and adolescent hip replacement surgery, unfortunately, which is necessary sometimes. We won't go through all these different etiology, but I'll kind of hit on a few case examples to highlight a few of these. What I would say is, if you have a patient who's an adolescent who comes in with hip pain, get x-rays. You know, if there's a trauma, get x-rays. If it's prolonged, if it's been going on for several months, get x-rays. If they come in and it's a couple days and it's not real significant, certainly you could try some therapy and anti-inflammatories for a couple weeks, but if that hip pain persists at all, I would never hesitate to get x-rays. Here's a kid who got tackled playing football, had this hip dislocation in Des Moines. He was appropriately taken to the operating room. He had that hip reduced. These are the films after their reduction. But what you see here is that small bit of bone down below the head, as well as that kind of crisp angle along the medial aspect of the head. So they called us and they, you know, wanted our advice. One of the new things we have here at the university is actually pediatric hip call system. So there's 3 of us who take pediatric hip call, who are specialized and able to kind of care for all the different potential operative treatments they might need. We got a CT scan there in Des Moines, and which showed this fracture of the femoral head and this piece floating down there in the lower part of the joint. So by calling us, we actually arranged a direct transfer. They came directly here to the hospital. I happened to be on call and took this patient to the operating room the next day. We did a surgery called a surgical hip dislocation, which there's been a few studies here in the last 3 or 4 years that have shown this to be a very reliable and safe way to manage these fractures. It's a bit of a tricky approach where you do an osteotomy of the trochanter, you open up the hip capsule and really dislocate the hip completely, where you get a full 360-degree view of the hip, where you can repair fractures. You can do a lot of stuff through this approach. So that's what we did for him. Here's an image of his case. It's not a great picture, but you can see there the entire femoral head is dislocated. You can see that red spot there on the femoral head, and that's that defect of the joint that was sitting down in the lower part of the joint. That's the articular cartilage, as well as a complete shear fracture of the medial fourth or so of the femoral head. So we fixed it. This image quality isn't great, I apologize, but he's got screws there, headless screws into the femoral head, as well as those screws you can see repairing my osteotomy site. He actually came back to clinic just yesterday. He's done great. He's back to running. He's back to playing all sports. He's back to doing everything he wants to do, not having any hip pain and doing great. These are his images from yesterday. No AVN to the head. Everything looks great. Another quick example, a slightly different presentation, but a totally different problem. 15-year-old running from some people, tried to slide over the front of a car to get away and had immediate pain in his hip. As you can see there on the right hip, completely slipped the physis, but the epiphysis slid posterior there. So he came, we got a CT scan, which showed a complete slip without any healing. So we did a relatively new technique here that's really been more and more popularized to try and minimize trauma, called the Parsh technique, where we actually just do a gentle reduction with a fingertip, get things lined up without doing a big open approach. It's just a small incision on the front of the hip, get everything lined up, fix it with screws there. You can see nicely reduced. Came back to clinic and has done great and gone on to heal this without any further hip sequelae. Similar presentation, but a totally different outcome and a totally different problem. So this is a 12-year-old who had 3 or 4 months of hip pain, had been seen by a physical therapist, had been seen, eventually was seen and got these x-rays which showed this slip. It's a low-grade slip. He had an outpatient appointment arranged with the local pediatrician, or excuse me, local orthopedic surgeon. Unfortunately, the 2 days between there, he slipped and fell. He then came back to the ER, now with this. Completely changes the problem. This is one that I would say, if you see a skiffy, if you see any sort of slip, call that day. We would transfer the patient here, non-weight bearing, in a wheelchair, to the hospital that day to operate on him. Because the risk is just this, that he goes on to get this high-grade slip where the epiphysis completely separates from the metaphysis, requires a totally different surgery, and much more complex surgery and poorer outcomes, unfortunately. So we took this kid back to the operating room the next day, proceeded with a big surgical hip dislocation, a capital realignment. We won't go through the details, but it's a much bigger surgery. We pinned his other hip as we did that last patient that you saw. Completely changed the outcome for this kid. So again, any sort of hip pathology, get an x-ray, get an x-ray, get an x-ray. And then if you see pathology, call call that day, email me, page me, call me, get in touch with us, because what we do, whether it may be bringing him direct transport to the hospital for admission and for surgery like that last kid, whether it's quick clinical follow-up that day or the next, whether it's outpatient management within the next couple of weeks, that's something that'll totally change depending on what the problem is. So the other benefit is, even if there's not acute pathology, we've got a lot of options, whether it's arthroscopy, whether it's minimally invasive stuff, whether it's realignment stuff. We have a lot of stuff that we can do for kids that wasn't available 15 or 20 years ago for mild pathology. So never hesitate. Kids with hip pain, there's a lot of options for treatment. There's a lot of variabilities that we would need to see them and be able to get them the appropriate treatment they need. So, excuse me, I skipped that. But any sort of lesion or anything on x-ray that you see, just send them our way so we can get them on the right path. Again, there's my contact information. So, long story short, we've got a lot of things here. We've got a whole new call system. We've got pediatric call every day. We've got hip call every day. We've got a system in place to be able to manage these, whether it's using our procedure room, whether it's seeing them in clinic the same day. We have clinic 5 days a week. Whether it's seeing them, if they're upstairs in one of your clinics and you want to call me and have me come up there, I'm happy to do that, or send them down to the clinic the same day. So we've really tried to streamline things for you and for us and to get the patients the care that they need.
Dr. Holt, I have a question.
Yeah, certainly.
Have a patient that presents with SCFE. Do we call the PAC transfer system, or are we okay just to call you guys?
Yeah, great question. No,
have mom and dad come.
Yeah, we have a whole separate system. So if you call the PAC, they should triage you. We have a whole separate SCFE call system now. Again, trying to eliminate a couple of these case examples that I shared of patients come into clinic, they just go through the normal referral process and come to clinic a week or two later. And so, yeah, if you call the PAC system, they have a separate tree that they follow that puts you directly in touch with whoever's on SCFE call for that day. Also available if you call our secretaries. All of our secretaries are aware of this as well. So if you call any of them, they know who's on SCFE call for that day, and we'll get you in touch with us, the surgeons, directly to manage the best kind of triage for them. Good question.
Okay, perfect.
Anything else?
I do have a question too. For adolescent patients, what is the age range that we should send to a pediatric surgeon like yourself versus the adult guys? Or is it just diagnosis specific and you guys just figure it out?
Yeah, some of both. Certainly if it's, young teens to a pediatrics, that would certainly come to kind of the pediatric side. Once you start getting into more of the skeletally mature teen up into the, 13, 14, 15, either myself or through the sports. So out at sports, they also have kind of the hip preservation clinic once a week. And so as you start to get into that kind of mid-teens to older, up to, really 50 or 60, certainly, can certainly come there or come to the sports clinic and be seen there, or I'm happy to see really kind of my practice more up to kind of mid-20s or so. But certainly call and we can triage. Again, we collaborate together. So whether they need an arthroscopy, if you call me and it's a small cam lesion and I can just set them up directly with Dr. Westerman and they can bypass me altogether, it saves them a visit. It saves them a trip here to Iowa City. So any sort of hip dysplasia or hip issues in the kind of adolescent to young adult age, if you call or fax or page or send a message through Epic, it's always, we can make sure we triage them to get the right provider.
What about the younger adults that have the spinal problems?
Yeah, either or. So, myself and the two adult spine surgeons here, we all work together. Certainly if it's more of a scoliosis, if it's more of a deformity in any sort of teenager, that's, myself and Dr. Weinstein are the providers for that. As you get into the kind of, again, the older, more skeletally mature, there are some situations where we might refer that to our adult colleagues, depending on what it is. But in general, we're the place to start for any child or adolescent with any sort of spine pathology coming through the pediatric orthopedics team is the place to start.
Perfect, thank you.
Well, thank you all very much. It's a pleasure.
Yes, well, thank you, Dr. Holt, for this great presentation. This has been recorded, so we will be posting this to our referring physician website, and we'll be sending it out to attendees today. If there are questions after this, feel free to reach out to the physician liaison team or to Dr. Holt directly. And just on behalf of the University of Iowa Hospitals and Clinics, we definitely want to thank Dr. Holt, but all of you for attending as well today. So thank you and have a great day.